Hello, this screencast is intended to provide some tips on completing the call and response care plan table that is required in semester 3 practicum for the Collab BSCN students on the Georgian College campus. This is a collaborative process that students need a lot of help from their CPSs to complete initially, and then hopefully by the end of the semester the students will be much more independent and ready to move into semester 4, where they will use this process again and hit the ground running. So some of you may be familiar with older versions of care planning, and this one in particular is linked to the theorist that guides the care in semester 3, and that is Patterson and Zerad, and that is why the process is called call and response. The first column is really where the student identifies the 2 calls that they will focus on for their assigned client or patient on the day that they are in practicum. The first step in this process is for students to prepare the night before, to have done some reading about their patient's diagnosis and their comorbidities, their tests if they had that information the night before, and also to have prepared medications if they were indeed assigned to give medications, and that would be starting in week 8. So that's the first step. The next step is to come to practicum and to attend report, to gather further data from report, possibly the chart, and then obviously to proceed to conduct their morning assessment, their head to toe, their vital signs, and to synthesize all of the data that's coming at them, and from that to then identify at least 2 priority calls that have presented through that data collection and synthesis process. Now, students initially may need some help doing that because they're not sure of how to synthesize and come to a focus for their care plan. But with a little bit of practice, they will get very good at this. The data that is used to support the identification of the call, so the either subjective or objective data should be listed below the call. So for example, if the call was acute pain, then the pain score, the OPQ or STU, focused pain assessment data would be listed beneath the call in this column. And that would apply for any call that the students identify. Now, sometimes students have a little bit of trouble wording the call, and I want to emphasize that how it is worded will come with time. It's not critical that they get it exactly like a traditional nursing diagnosis. However, that does help some students. In their MedSurg textbook, the Lewis textbook, there is a list in Appendix A that includes some of the suggested biomedical calls here on the second page. I've pulled the ones that I think are most commonly going to be used in semester 3 MedSurg setting. Note that this isn't all of them. They're not in alphabetical order because they're grouped according to a classification system in that table, but I've listed them here to help get students started if they're struggling. Note that any of the calls could be an at-risk call or an actual call. So there might be impaired tissue integrity or risk for impaired tissue integrity. But ideally, students will be choosing at least one that is actually a call and not an at-risk call. So further information about this can be found in Appendix A, or if you have NANDA references, they may be of use as well. Note that it is potentially harmful to label patients with any calls or labels that would be inconsistent with humanistic nursing theories. So for example, impaired coping or impaired resilience or ineffective role performance, these These are labels that are used in the NANDA system that we would consider inconsistent with humanistic nursing theory, and we strongly recommend that you encourage students not to use these. So when identifying a call that relates to a non-biomedical health concern, the student can simply put the call in the patient's own words or describe the issue from the patient's perspective. So for example, the call might be fear of facing responsibilities at home following surgery, or for example, I am very worried I will not be a good mom when I'm recovering at home, instead of using the label ineffective role performance, which can be viewed as a negative label and is potentially harmful and doesn't lead or suggest that there is open dialogue that comes to a mutual understanding through intersubjective relationship. So I think you'll find a lot of the biomedical calls that you need in third semester are listed here, but there may be others in the table in the textbook that you could use. The second column is really just a small amount of pathophysiology or pathogenesis related to the biomedical call, and some students may need to actually utilize their textbooks at home to complete this section, depending on what resources they have or do not have available to them while they're in clinical. So if they have to leave this empty until they get home, that's totally fine. The third column is really a list of interventions that comprise the nursing response to the identified call. And I'm sure many CPSs will be familiar with having done care plans themselves in school, and I've listed some of the traditional interventions that nurses would include in a plan of care, and this could include assessments and their frequency, any interventional care, such as dressing changes, etc., any safety measures that have been put in place, any specific labs or tests that require monitoring or that are directly related to the call, medications and specific timing if that's relevant. So for example, administering a bronchodilator Q4H for someone with ineffective airway clearance. Any collaborative care provided with members of either the interprofessional team members. And we encourage strongly that to meet the outcomes for this semester, that students are interacting with members of the interprofessional team weekly, at least once per week. So meaning, remain in the room when physio comes in to provide their treatment plan or to decide on a treatment plan, and be part of that collaborative piece so that the student can also follow up and provide range of motion or transfer according to what the plan the physio has set out. We don't want the students missing out on these wonderful learning opportunities. Also, if care is provided by the nurse that's assigned to the patient, the registered staff that is assigned to the patient in the agency, then that can be included here, and it's just indicated that it was provided by the most responsible nurse. Some care may be delegated to other members of the team, and that could be included here if it's relevant. Any health teaching or discharge planning. Subsequent to the day of care, students may in fact identify retrospectively care that could have been or should have been included. Maybe they forgot to weigh somebody, maybe they forgot to research or monitor a specific lab value, for example. Maybe they forgot to do a specific kind of exercise with their patients. They could include that here retrospectively to complete that iterative reflective process and to complete their plan of care. The fourth column really is just an adjunct to the third column. It's just their support for the interventions that have been identified here. So the student would list the corresponding rationale using a numbering system identical to the third column. And each rationale must have a citation, so either from a textbook or a best practice guideline or an agency policy or procedure. that is essential to it is essential that the student be able to provide a rationale for each intervention that they've provided in column 3. Final column is knowing that I have nurtured well-being and more-being for my patient. So well-being really requires a list of the expected patient outcomes for an identified call, and then indicating if the expected patient outcomes were met or not. This could include a reassessment of findings, both subjective and objective findings. So for example, if the call was 10 out of 10 acute severe pain at rest, the outcome ideally would be pain less than or equal to 3. And so if the pain score was reduced to that, then the outcome would have been met. And this can be done in point form very clearly and succinctly. More-being is really the new piece for students, I think. And, well, it's all new, but more-being relates to Patterson and Zerod's theory, specifically that the aim of nursing from the perspective of the nurse, and the nurse would be nurturing human potential. So the student might ask themselves, did I nurture human potential or help the patient become more as humanly possible in his or her particular life situation in the here and now? So being all that one can be in the moment, or perhaps learning from the encounter, or perhaps achieving the best possible outcome in the moment, or increasing the possibility of making responsible choices. Note that more-being is more and different than well-being. More-being can only be addressed if the nurse engages in an intersubjective transactional relationship with their patient, and when they explore the person's viewpoint and experience of their current health situation, only then can they truly move towards nurturing more-being in the situation for the patient. And not all students will be able to do this initially. They may be so focused on the tasks and the skills that they may not engage in an open dialogue and ask the patient open-ended questions such as, what has this been like for you to be admitted to the hospital? What has it been like for you to live with this illness? What is most important to you right now? What would you like to see happen? When the student is able to ask these types of questions, only then can they truly get at what more-being might be for the individual that they're providing care for on a given day. And of course, sometimes there will be overlap between more-being and well-being. So if relieving acute severe pain enables a patient to move closer to being able to go home, where they're the primary caregiver for a spouse at home, that might be the connection between the well-being and more-being. But sometimes nurturing more-being may be unrelated to the specific call that is being focused on, and that's okay too. So in a nutshell, we're hoping that students can get very comfortable with this care planning process. They could require quite a bit of support initially to be able to identify what are the key calls, the 2 key calls for their patient. And we encourage the CPS to focus on this when the student has completed their head to toe. Perhaps the CPS will accompany the student to complete a head to toe and then say, what do you think the priority calls are for your patient today? And then assisting the patient or the student to complete this in vivo, right then in the moment, jot down with a pen and on the paper, and to edit and scratch out and add in throughout the shift of care. It should be a work in progress. It should be a living document. Note that the care plan is not a worksheet. The student may also have a worksheet that has lists of tasks and skills and a place where they collect information, but that's different than the synthesis required for a plan of care. And our goal is that by the end of this semester, the students will be comfortable completing a plan of care for their patient. I hope this little screencast has been helpful, and should you have any further questions, I encourage you to contact your clinical faculty support person or your your health and healing teacher in either on Thursday or Friday during the week. Thank you. Bye for now.